have the pleasure to present our experience in the treatment of the ruptured AAAs. We go a little bit apart from the thoracic arch and descending aorta. So the title of my lecture is Treatment of Ruptured AAAs, Our Experience After 1,400 Operations. This large number of the operated patients is because of the concept of vascular service in our country, namely our emergency vascular service is highly centralized, and almost 3/4 of all ruptured AAA cases are treated in our institution from our country that have about 7 million of inhabitants. On this diagram, we see that in the last 28 years, we treated more than 6,000 AAAs. Among them, about 23% were ruptured AAA, making almost 1,400 cases. We published our really broad experience in several publications, and our last publication, so about 2 or 3 years ago, published in Annals of Vascular Surgery, presented the series of more than 700 patients, which is, according to the literature, one of the largest single-center series published yet. What is interesting regarding the mortality in the ruptured AAA is that it is almost unchanged in more than 6 or 7 last decades since first reports from Cooley and DeBakey in 1954, where they reported a mortality of 50%. In the next several decades, we see that the average mortality, overall mortality in the world is still about 50%. And one relatively recent 50 years meta-analysis presented only 3.5% decrease in mortality in every 10 years, which is really, really slow progress. And the other meta-analysis presented even no improvement in mortality in treatment of these patients. This is perhaps for the reason that these patients have very severe pathophysiologic changes during their disease. Classical triad of symptoms we are presenting with shock, abdominal back pain, and pulsating mass can be seen in only about 1/3 of patients, and the clinical diagnosis can be very difficult and challenging in some patients. According to the laboratory findings of admission, although we calculated some cutoff values that are significantly connected with mortality of these patients, our experience presented that very often normal values of initial findings on laboratory are possible due to hemoconcentration, and that should not seduce the surgeon to announce that the patient is not bleeding and the patient's aneurysm has not ruptured. Ultrasound as a broad method of diagnostics is not reliable for the conclusion or acceptance of rupture of the aneurysm. However, it is good technique for the fast orientation. If we utilize fast protocol, we can perform a good orientation in just several minutes, and due to its broad availability, we use this method initially in about 80% of our patients. However, the most adequate method to conclude or to exclude rupture is CT or multi-slice CT scan. It is the most precise method for presenting a retroperitoneal hematoma or other liquid collections. Also, we can have good insight to associated pathology, and of course, if we plan endovascular repair, it is inevitable procedure. However, there is a certain controversy regarding the time frame for performing CT scan, especially in hemodynamically unstable patients. So, the authors of the prospective randomized trials claimed that it is difficult to predict the continuity of hemodynamic stability during CT scan. In order to avoid some misdiagnosis and some dilemmas in hemodynamically unstable patients, we constructed this relatively simple algorithm patients with obvious sign of a clinical triad for lateral aneurysm, we proceed to urgent operation without any additional diagnostics. If the patients are relatively stable, we perform fast blood count and urgent abdominal ultrasound. If the diagnosis is confirmed, we proceed to urgent operation without additional CT scan. If the patient is completely stable and we have some dilemmas regarding the anatomy of the aneurysm, if we suspect on a suprarenal aneurysm or even thoracoabdominal aortic aneurysm, or the patient is completely stable, then we only perform additional CT scan. Of course, after that, the patient is admitted to the ICU unit and prepared for the urgent operation. For sure, the patients with, that are unconscious on admission with the cutoff values of pressure below 90 millimeters of Hg, especially patients that have been previously reanimated, are not candidates for any kind of additional diagnostics. They are candidates for fast proceeding to the operation room. We adopted the concept of preoperative permissive hypotension with allowed pressure between 70 to 80 millimeters of Hg before aortic cross clamping. One important issue that we adopted is advice given by Peter Glovitsky at the end of 20th century, where he stated that the selection of patients should not be done and the possibility of aortic repair should be given to almost every patient regardless of his general state on admission. Searching through the literature several years ago, we were astonished by high rejection rate of AAA rupture patients in the literature, ranging between 20 to even 40% in some hospitals in the States or in Great Britain. We also adopt almost unselective approach to almost all patients with rupture AAA. Regarding the surgical approach, we adopted the concept from Stanley Crawford, presented at the end of the 20th century, with fast supraceliac aortic cross clamping. And regarding the type of reconstruction, our advice is to go for the most simple reconstruction because it gives the best possibility of survival of our patients. Some tips during the operation. In order to perform the simplest possible procedure, we can tolerate the iliac aneurysms even up to 3 or 4 centimeters. If we must go for aortobiliac bypass, we should perform first technically less demanding anastomosis first. If we have to go for aortobifemoral bypass, we should take care of hypogastric perfusion, and if there is a need, we must perform sometimes reimplantation of the inferior mesenteric artery. At the very end of the operation, we strongly recommend the evacuation of retroperitoneal hematoma in order to avoid postoperative abdominal compartment syndrome. Our experience presented that prolonged aortic cross clamping time over 45 minutes, duration of surgery more than 200 minutes, poorly controlled tension during the operation as well as urine output, and the need for transfusion of more than 5 units of blood are significantly connected with mortality in our patients. In postoperative period, the most dreadful complications are, of course, respiratory failure and multisystem organ failure, highly connected with poor outcome. We face the renal failure relatively often, between 18 and 28%, depending on the period of examination, in about 1/4 of patients requiring dialysis. Also very important possible complication we should think always about is colonic ischemia that we faced between 2.5 or even 9% of our patients. So what we have learned from this 28-year period and 1,400 patients, there are some things that we can not give impact that are uncorrectable, so-called uncorrectable parameters, but there are some preoperative parameters that are correctable. We advise the concept of permissive hypotension before starting the operative procedure, before aortic cross clamping. We advise to shorten admission surgery time as much as possible, and especially in unstable cases, we should avoid all unnecessary diagnostic procedures, any kind of hesitating and attempts of stabilization of patients in ICU. We shouldn't wait for allogeneic blood. Instead, we should prompt the operation with the use of cell saver. Regarding intraoperative parameters, of course, we cannot impact on aneurysm size, localization, and type of rupture, but we can go for far supraciliar cortical clamping. During the surgery, we should go for the most simple kind of reconstruction and taking care about systolic pressure and the urine output. In post-operative period, we should put every effort to avoid respiratory complication by timely extubation. Polytransfusion syndrome can be put aside by the use of cell saver. However, if prolonged ventilation is needed, we should go for tracheostomy. Multisystem organ failure can be fought by invasive monitoring of hemodynamic parameters, timely hemodialysis, and multidisciplinary approach. We should take care about and think about possible surgical complications like colonic ischemia and the development of abdominal compartment syndrome by performing early colonoscopy or delayed vacuum assisted closure. Abdominal compartment, if it is developed, can be sanated by vacuum assisted closure, and the suspected colonic ischemia should be concluded or excluded by early colonoscopy and by thinking of significant preoperative or postoperative parameters that can raise significant suspicion of development of colonic ischemia, and of course early reexploration or reoperation in those patients. So, adopting all those recommendations and by increasing experience, we managed to decrease the mortality of our patients from the first period where it was over 50%, in the second period to 40%, where the most important procedure was introducing of cell saving. In the third period, a further decrease of 35%, and at the right moment, now our overall mortality for after AAAs is about 30%, which I think is relatively good. At the end of the lecture, a few words about endovascular repair of after AAA. In the contrast with elective repairs, prospective randomized studies presented no significant difference in mortality versus open repair, with the Dutch study, especially IMPROVE study, and ECHR study. However, in most institutions, the CT scan time frame is questionable, especially in unstable patients, and logistic problems with the need for all-around on-call experienced surgical interventional team, and of course, especially for the developing countries, expensive and complex diagnostics and therapeutic equipment. So, despite of that, times are changing, and in this very year, we introduced our new hybrid unit. We also have a small selection of on-shelf endografts and, of course, increasing team in experience in endovascular repairs. However, always the problem is time to gather multidisciplinary team in unstable patients. They have to be all around all the time. It is not possible yet. And of course, the cost of endovascular settings, which is really about 10 times more expensive than conventional vascular grafts. So at the moment, we still see these different procedures, open, repair, and endovascular, more as comparative, but not competitive methods yet. So our small experience in urgent endovascular repair, although we perform more than 300 elective endovascular repair, we performed 2 urgent repairs of aortocaval fistulas, 5 contained ruptures, 4 rupture AAAs, but all patients were stable because time frame was not enough to gather multidisciplinary team. And what is the most common situation for utilizing urgent EVER is symptomatic patients that should be treated the same very day or at least the day after, which give us enough time to get all the needed settings for to perform this kind of procedure. We had only one lethal outcome from all these patients and one early graft thrombosis, which had to be treated by axial or bifemoral bypass. Just one interesting cases in artocaval fistula in the patient where we performed endovascular implantation in the inferior caval vein in order to stop the fistula, and after that the classic implantation of endovascular aortic graft. The patient also had the neurofibromatosis, which was also one of the factors that he was selected for EVER. Post-operative result is quite good, and in conclusion we can say that open surgical repair of ruptured AAA is still the method of choice for the majority of countries, especially developing countries, due to logistic problems. However, endovascular repair still remains very challenging option for the future. Thank you very much for your attention.
Thank you, Professor Markovic. Any comments, questions? Professor Chiesa, yes, please. Microphone.
Very compliments for your fantastic experience. It's really one of the most important experiences in the world. And I think that today exists a big mistake, a big compromise about the situation of the aneurysm. If there is a true rupture, for true rupture I say blood in the peritoneum and blood in retroperitoneum free, I think in this situation it's possible to treat the patient only with open surgery, because you have otherwise you have a very terrible situation post-operative of pressure, and it's very important. If you have a contained rupture, compartmentary syndrome instead, if you have a contained rupture, it's possible to use EVER. And so everywhere in the world treat and say the endovascular for ruptured aneurysm is not true. We are contained rupture. This is my idea, my impression. What do you think?
Thank you for your comment. And of course, I can completely agree with your conclusions, especially in the countries where there are logistic problems with gathering the multidisciplinary team. The time frame is very complicated, and the expensive equipment. So, of course, at the moment, the open repair is the first line of choice, especially here.
Completely agree.
Yeah.
Comment from Professor Kostic, yes?
I'd like to ask Professor Chiesa, what do you think about the experience that years behind us, Mario Lascia is talking about ruptured aneurysms when he puts a balloon occlusive catheter, he does EVER, and then he does the decompression of the abdomen. What is your opinion about such surgery?
Thank you. I am a very close friend to Mario Lascia, and the problem is what I anticipate. One thing is true rupture of the aneurysm. You know very well the true rupture of the aneurysm. The patient in complete shock, 60 for pressure, shock, the abdomen with blood inside and in retroperitoneal is a patient with a problem of survival. And in this situation, I think it's only possible to open the abdomen and to put a clamp where you can, like said Crawford in the time. For contained rupture, you can do everything with contained rupture. Endo, other endo, open, you can do. But the really difference in between complete rupture and contained rupture, this is the problem. And Mario Lascia, I speak a lot of time with him about this, treat contained rupture. Because true, no, he said that he treat every type of the patient, but the patient with complete rupture die with endovascular. This is my opinion. This is my opinion. This is my opinion. There are terrible compartmental syndrome. The patient don't put urine. The patient problem of respiratory problem, all the problem, coagulation problem, everything, you know. And the patient is very, very old. Is the same situation, absolutely the same situation. This is what I think. Personal impression.
Professor Davidovich, please.
Only one short comment. The placement of balloon occlusive catheter in supraciliac position is really nothing new. That procedure has been described more than 3 decades ago. That is a true. I only prepared some historical lecture. I found that in the literature. Initially, some surgeons recommended left midi thoracotomy and clamping of distal thoracic aorta for primary stabilization of the patient and to prevent cardiovascular collapse before laparotomy and anesthesia, but is new traumatic insult for the patient that aggravate coagulopathy, hypothermia, etc. The second option was a placement of balloon occlusive catheter using transfemoral and brachial approach, but in majority of cases the problem was malposition of the balloon, and due to this it was not safe procedure. In my opinion, the best option is fast supraciliac aortic cross-clamping. An experienced vascular surgeon needs less than 10 minutes from the initiation to laparotomy to supraciliac aortic cross-clamping.
My opinion also is that placing a balloon is not so easy. Once I had that experience because I had a block on the upper abdomen regarding the supraciliac clamp. I had a problem with the bleeding aneurysm. I tried to put the balloon. I just couldn't pass the huge sac and the thrombus. And at the end, we finished dissecting the supraciliac part of the aorta as fast as we could. That's my opinion.
Yeah. Thank you, Professor Markovic. For the sake of time, we go further on. I invite Dr. Rinaldi for his